So good afternoon, everybody. I am Rahul Chobe from OrthoTV for today's webinar, Spine Surgeon Web. So today's topic is Valgus, its management tips and pitfalls by our renowned consultant foot and ankle surgeon, Dr. Amrish Bidaye. Dr. Amrish Bidaye has a vast experience with foot and ankle disorders, foot and ankle orthoscopy and meniscal repair, traumatic injuries, complex deformities in foot and ankle, and also the trauma injuries in leg, foot, ankle, arthritis also. I'm handing over this session to Dr. Amrish Bidaye. Welcome, sir.
Thank you, Rahul, for inviting me to give this talk today. I'm going to talk about Hallux valgus and management of it. We've got a good panel with us today. We've got Dr. Ravindra Panse, who is a consultant orthopedic surgeon who specializes in diabetic foot surgery. We also have Dr. Rakesh Gosavi, who is a trauma surgeon. We were supposed to have Dr. Sampat Dumre Patil with us as well today, but we think he's stuck in a case somewhere. So hopefully he can join us later on. He's the ex-president of the Indian Foot and Ankle Society. So hopefully he'll join us later. But meanwhile, we'll start this talk about Hallux valgus, and then we can have a little discussion afterwards. Now let me share my screen. Okay, so we're going to talk about Hallux valgus. So Hallux valgus is not very commonly sort of discussed topic in India, primarily because the incidence is much lower than in the West. In the West, it is very common, whereas in India, it is there, but not as much. Also, our people don't wear that many shoes. So most of our people wear sandals, chappals, things like that. So they get less trouble with this. And there is also a reluctance of any surgical intervention in things like toes, which people consider to be not that important, which leads to later on problems, which is why it is not that commonly seen here. So, okay, so let's talk a little bit about the pathophysiology. As you know, Hallux valgus commonly is called bunion. So it comes from the Greek word which means turnip, which is like a red and white vegetable. And that sort of signifies the swelling that you get in it. There is a very strong female preponderance with almost 6:1 as opposed to the males. It has a very strong sort of congenital history with it. I used to work in Scotland, where there are a lot of people of Scandinavian origin, and this is a very, very common problem there. So we used to operate almost 6 to 8 Hallux valgus in a week, every week. Whereas in India, it is there, but it is not as much common. In India, it is more seen in the Parsi community, which generally shows this Hallux valgus in it. You also can get it non-congenital with, again, people who wear high heels, tight shoes, again, which is why it is probably less seen in India. Probably one of the most common causes to see it in India is rheumatoid arthritis. You also get it in sort of advanced flat foot and sometimes following trauma and some neurological disorders. So looking at the anatomy of the foot, this is a view from the plantar side. This is the sesamoid complex that you see under the first metatarsal head. This is the joint that is in question, which is the first metatarsophalangeal joint. You have this strong muscle on the lateral side, which is the adductor hallucis. And you've got a muscle on this side, which is called the abductor hallucis. They attach to the base of the proximal phalanx of the big toe. And you also have these ligaments on the side. So these muscles and ligaments play an important part. So how does this develop? So this strong adductor hallucis muscle, especially if you have some ligament weakening and loosening, say like happens in rheumatoid arthritis, this strong muscle starts pulling the toe on the lateral side. You have this, so this is again from the bottom. So they've shown the extensor hallucis tendon as a dotted structure on the top. So when this starts happening, the extensor hallucis muscle starts shifting to the lateral side of the axis, center of the axis of this metatarsophalangeal joint. And once that happens, that also, so whenever it pulls in this direction, this deformity gets accentuated. Similarly, the whole sesamoid complex is displaced on the lateral side, and you have the, as you can see here, the flexor hallucis brevis muscles that are attached onto the sesamoid complex, and they also pull. So everything starts pulling the big toe towards the lateral side, which is why you develop this classical deformity, or the bunion as they call it. Okay. So this is a cut section. Again, that shows us the same thing. So this is the cut section of the metatarsal head. You've got the extensor hallucis brevis muscle that they've shown on the top. And these are the two sesamoids, the medial and lateral sesamoid. The two muscles, abductor hallucis and adductor hallucis, and the flexor hallucis brevis muscles. What is interesting to see in this picture is that there is a structure here called the crista, which is like a bony ridge that you get at the base of the metatarsal head, and the two sesamoids sit on the either side of it. So as you can see, with like continuous force that happens, that crista gets worn out, and then the whole structure is translated laterally. So actually, when I repair these, I take a stitch through this abductor hallucis when I'm doing the soft tissue repair, and actually pull it and stitch it up to the capsule up here, and it drags this whole thing on the medial side. So what do patients complain of? So the things that patients complain of is generally nothing. So quite a few times it is completely asymptomatic and painless, which is why most people don't need anything. But when they do complain of something, it generally happens because of wearing shoes. And the prominence that you have on the medial side starts rubbing against the shoe, and that gives rise to bursitis. And that is what gives rise to a picture like this. So if you can see this redness and swelling that you have, and that is really annoying to patients. What is more annoying, however, is when the lesser toes start getting affected. So as you can see, if there is not much room on this side for this toe to go. So if the deformity continues, what it does is it either goes under the second toe or over the second toe. And that is when people start getting more problems. So you get a picture like this where the toe climbs over so overriding second toe, you get over the hallux. And then this bit, the joints of the second toe start rubbing against the shoes on the top, and that causes a lot of problems. The other thing that happens is when the second toe goes up like this, it pushes the metatarsal head down. And when it pushes the metatarsal head down, you start developing cons, and these cons are like you can see in this picture here. So these cons are extremely painful and problematic, and people keep going to their surgeons and they keep sort of trimming these cons, and they keep coming back, because the problem is that the metatarsal head is prominent under here rather than anything else. So generally in a picture like this, when you tell a patient that they want surgery, like you need to do surgery and you need to do a hallux valgus correction, they say, but this is not painful at all. Why are you sort of touching this? I mean, you have to tell them they have to make space for this second toe to come down. And so the second toe always troubles more than the big toe in this condition generally. So what do you do when you have a patient that comes with this? So apart from your normal workup that you do, you have to rule out some other conditions like gout. So if you see in the previous picture, so the first picture that you have here, this could easily be gout. Okay, so you have to rule out that there is no gout that is giving rise to a red swollen first metatarsophalangeal joint. You have to rule out conditions like rheumatoid arthritis, because the management is fairly different and they will need some medical management before. Flat foot, again, generally flat foot will have sometimes presence with hallux valgus, but they are not that symptomatic. So you may need to sort out problems in the hind foot in a patient with flat foot. And diabetes, you all, of course, need to rule out and be more careful in. You also have to check for, so I'm only mentioning specific things here, apart from the other normal things that you do. So you have to check for hypermobility of the first ray. And for that, you do something called as a root test. So in that, what you do is you hold the lesser metatarsal heads and you hold the first metatarsal head and you see if there is any translation, if it is moving upward. Normally it does, but it is generally less than 1 centimeter. About 5 millimeters to 1 centimeter is considered normal. Anything more than that and it is hypermobile. Why this is important is because this is one of the major causes of hallux valgus if you've got hypermobility of the first ray. You also have to check for whether there is any arthritis in that joint. And to do that, you do what is called a grind test. So it is very similar to the grind test that you do for CMC arthritis for the hand. So if you take the big toe and you sort of rub this down, you push it down and you rub it. So you do that. So, okay, I don't know if you can see. So you sort of do this movement. And generally, if there is arthritis of the metatarsal head, that will cause pain. And the most important thing is to get weight-bearing X-rays. Why weight-bearing X-rays? Because the picture sometimes dramatically changes when the patient stands up. So X-ray that looks pretty straight like this can look like this when the patient stands on it. And people always complain about taking weight-bearing X-rays because they need some specific materials and place to do it, but you should always insist on getting weight-bearing X-rays for any problems related with the foot and ankle, because the picture can change, as you can see. So why we need the X-rays is because we are looking for these angles. These angles tell us, help us in the classification of the problem. And there are two main angles. So one is the hallux valgus angle. So you draw one line. So this is you do it on the X-ray, okay, weight-bearing X-ray. So you draw one line from the center of the first metatarsal, and you draw another line in the axis of the big toe or the proximal phalanx of the toe. The angle between that is called the hallux valgus angle. The second angle is axis of the first metatarsal and axis of the second metatarsal, and that gives you an intermetatarsal angle. There is a third thing that they've called DMMA here. It is also sometimes called DMAA. It is called the distal metatarsal articular angle or distal metatarsal metaphyseal angle. So the cartilage at the end of this bone normally sort of sits a little bit off 90 degrees, okay, about 5 to 10 degrees. So in some patients, however, it is really, really slanted. In those cases, this angle will be more. So this line, so you draw a line along the base of the cartilage cap. And if that is really big like this, when we do the surgery, we shift the whole thing. And just shifting, if the articular angle is like this, it's not going to help. So you have to do an additional thing where you shift and rotate it up. So I'll show you that later. So then we come to the classification. So in classification, we check these angles and we classify it as mild, moderate, and severe. So if it is less than 30 degrees of hallux valgus angle, it is considered mild. 30 to 40 degrees of hallux valgus angle and less than 20 degrees of intermetatarsal angle is moderate, and more than 40 degrees and more than 20 degrees of these angles is considered severe hallux valgus. Then we come to management. So can you conservatively manage these conditions? Of course you can. We'll see where. So as I said, majority of patients are asymptomatic and they can be managed conservatively. In patients who have got very mild deformities, you can try conservative management initially. Symptomatic but mild deformity, okay. It might not correct the problem completely, but it can definitely reduce the progression of the disease. Okay. And how do you do conservative management? You use various splints and spacers. I'll show them to you. You ask the patients to use wide shoes rather than tight, narrow shoes, and you ask them to avoid heels. Okay. In America, if you go, they have in every size of shoe, they have a wide shoe available. And that is probably because they have wide feet, much more commonly found out there. And these problems are also much more common there. So wide shoes really help. Unfortunately, in India, we don't get that wide option in most shoe sizes. So these are the options that you have for conservative managements. These are the toe spacers. They work to an extent. However, sometimes, normally it comes as just this spacer. And what people tell me is that it just flips out of here. So I like this one, which comes with a hole for your big toe, and it also has a little gel pad here. And this helps. So this is called a bunion sleeve on this side. So this is very comfortable and patients love this. You can actually get this on Amazon. And it has a little bit of elasticity, so it holds this big toe in a straight position. It also has a gel pad. It is very soft and quite flexible. So patients love this. It will stretch out and after like 6 to 8 months, and they'll need to get a new one, but they're very cheap and very effective in mild deformities. Now this is a splint. This comes, there are static splints, and this is a mobile splint. Generally, people do not like these. These are very uncomfortable. Okay. The only use of these things would be probably as a night splint to hold it in this position while the patient is sleeping. I wouldn't give this to a patient who's walking. I mean, that is what it is suggested for, but patients hate these. So these are not that great. These are very good. And they're very cheap. Okay, so next we come to surgical management. So where do you consider surgery in these patients? If a patient is symptomatic, if they're having problems, they will tell you, I cannot wear any shoes, I cannot walk for too long. That would be a patient to consider surgical management. People who have got problems with their lesser toes, they are very difficult to manage conservatively. Okay, so in these patients, generally you will need to do a surgery where you have to sort out the hallux valgus and the second and sometimes third toe as well. So when a patient comes to you with a symptomatic hallux valgus, then you take into account the age of the patient, grade of the deformity, any other comorbidities, whether they have got arthritis and hypermobility of the first ray. So you take your x-rays, you measure the angles, and then you decide what surgery you're going to do. Comorbidities, as I said, you look for diabetes, gout. There was one instance where I was a resident in the UK, and we took a patient for a scarf osteotomy. And after the first cut, cheesy material started coming out of the metatarsal head, and it was gout. So it was a very embarrassing situation for us because we hadn't completely ruled out that particular thing earlier. And then it became very difficult to manage. So in surgical correction, you've got proximal osteotomies, shaft osteotomies, and distal corrections as well. And there are multiple treatments of these. So these are just a few that I've shown. So Aiken procedure is on the proximal phalanx. Here, people generally used to started off just by doing the bunionectomy or exostectomy, as they've shown. So you just cut off the lump and you do a soft tissue repair. They always recur. I would not do those. Okay. If you're doing something, then you should always do a bony correction. Don't do just the soft exostectomy and the soft tissue correction for these. Chevron osteotomy is a very popular and a good surgery. Mitchell osteotomy is one that is done a little bit proximally. I have seen these being done when I was a house officer in the UK, but they've now stopped because they gave very bad results. There are also proximal osteotomies that are available. Okay, so there are many more osteotomies than these that I have shown. And that is one of the reasons why forefoot surgery got such a bad result, because there were a lot of these procedures that were done that actually gave not ideal results in the past. But thankfully, most of them have now been stopped, and we are doing tried and tested and evidence-based surgeries now. So I primarily offer 3 types of surgeries for these. the most sort of common one is called the scarf osteotomy. Okay, so it is an osteotomy of the shaft. It can be done in mild to moderate hallux valgus. I generally don't do it for severe unless it is a very young patient. It is an inherently stable osteotomy. So it is pretty good. You can get the patient walking sooner without too much trouble. And as I said earlier, if there is a DMMA that is very tilted, then you can correct that with the same osteotomy, just with slightly different cuts. And if you're doing in a mild to moderate hallux valgus, even though you correct it, there is a possibility that the deformity can recur. So you just need to mention this to the patient. Okay. Now, this is a little thing that, as orthopedic surgeons, we are called carpenters. But this particular osteotomy is actually, we have borrowed it from the carpenters. Okay. So this is an old woodworking technique that carpenters have been using for ages to join two pieces of wood. So this is called a scarf cut. And this is exactly what the pioneers of this osteotomy borrowed from age-old carpentry techniques. So this, I'm just showing a scarf cut in a piece of wood here. Okay. This is how the osteotomy looks. So you take these two parallel cuts and you take a shaft cut like this, and then you shift the head side medially. Okay. So first you take off the sort of bunions or the bony prominence on the side, and then you shift the whole thing to the medial side, and then you fix it with a couple of screws. And if, as I said, if the DMMA is too tilted, then instead of just shifting it, you can take slightly horizontal cuts and shift and rotate it as well, and that will correct the DMMA. Okay. And this is how correction looks afterwards. As you can see, the intermetatarsal angle in this patient is 19, and post scarf it is 9. And in this, they've also done a Akin osteotomy where they fixed the distal phalanx as well with a small. I'll mention that later. The next surgery is a Lapidus procedure. Now, this is one that you use if there is hypermobility of the first TMT joint. Okay, this is generally there when there is a large but correctable deformity. Generally happens in younger patients. And what you do is you fuse the first TMT joint in this. Okay, so the hypermobility is happening at the tarsometatarsal joint, and you correct the intermetatarsal angle in these and you fuse them. Okay, now this is a procedure that is very common in the United States. In America, it is done very commonly. I trained in the UK. It is not done much, that much in the UK. That is probably because most of the patients are, whilst their deformities are pretty big, they are not very symptomatic in these, but in America, they are all operated on. Okay. The traditional way to do these is with screws and plates, but nowadays they've got plates. And since the Americans do a lot of these, there is a huge advance in the plates that you get for these. So you get plates with wedges, you get plates. Nowadays, the plantar plates are much more common. And it is a very advancing thing that is happening. So as you can see in this particular picture, this is a big hallux valgus, and they have fused this first TMT joint with this plate here, and the metatarsal angles are corrected. And the third surgery that I offer for these patients is a MTP fusion. So when do you do MTP fusion? If there is a severe deformity, if there's more than 40-50 degrees of deformity, just doing a scarf is not going to help. Okay. If the patient has any arthritis, you obviously go for MTP fusion. Generally in older patients, if the patient is more than 60 something years old, you want to give them one procedure that is likely to last and give them good benefit, rather than giving them a like a osteotomy in which the deformity may recur. Then you do these. Or if you have a patient who has rheumatoid arthritis, so then you do MTP fusion. So as with all fusions, you have an ideal position of fusion in this. And the position for this is 10 degrees of valgus. And there is, most importantly, around 10 degrees of dorsiflexion and neutral rotation. Now, this 10 degrees of dorsiflexion is very important. And you have to tell this to the patient that when you see your toe, if this is your foot, your toe will be sitting up like this, okay, like that. And that is important because when we walk, when we are walking, I'll show you on this. So when we are walking, if your toe is down or neutral, then you cannot do a heel off, okay, like this, okay. But if the toe is up here, then you can do a heel off. So whilst the toe does look up a little bit, it allows you that heel off, which is very important. If you fuse it in neutral, then the patients will really complain. So that has to have a little bit, so the toe has to be up a little bit. It does flex in the intermetatarsal, interphalangeal joint. So it does touch the ground, but so you shouldn't put it like all the way up here. So only about 5 to 10 degrees, okay, neutral rotation. So this is very important for fusions. Earlier, we used to use screws, and they are still being used some places. Staples are coming in as well, but I prefer using plates. Why? Because the plates have a inbuilt, so all the ideal position is inbuilt into the plate. So you just have to center the plate on the two bones, and if you tighten it, it will put it in the ideal position. I also like to put a screw across the joint like this to compress it. Okay. And as you can see here, I don't know if you can see, the toe is not completely, it's not on the same plane as this one. It's sitting up a little bit. So what are the complications of this surgery? So it looks like a very simple and not a problematic thing, but it does have lots of problems if not done correctly. And that is why lots of people are put off by operation. So I have a patient with a very severe deformity who have been asking him to do a fusion, but he knows somebody who had this surgery done badly and they really struggled to walk. So he's refusing this surgery. So historically, forefoot surgery hasn't had very good results as compared to hindfoot surgery, but things are changing now. Okay. So the nerve damage is common in this condition. So the dorsal cutaneous nerve goes very close to where your scar is, and the course is slightly variable also. It is a bit on the medial side, but it is possible that it can get involved in your scar, in your stitches, something like that. And you have to warn the patients of slight numbness in the toe. This is a very bad complication to have, which is called hallux varus. So you had a toe that was going in and you corrected it, and now it is going out. Now it makes hallux varus is very difficult to deal with in terms of, the no shoe will fit on your foot if you get hallux varus. Metatarsalgia. So this is pain under the balls of your feet. So you do a surgery for a bunion and then you give them another pain, which is pain under the ball of the feet. Lesser toe problem. If you already have problems with your lesser toes and you correct them, they don't behave as well as the big toe. The joints are very small. Generally, any operations that involve the lesser toe involve some sort of a fusion of these, and the joints are very small. Sometimes they don't fuse. They very easily develop contractures, and the toe will sometimes go up later on. So lesser toe surgery also has a lot more problems than the big toe surgery. Okay. This is a complication especially there for your scarf osteotomy, where you can get a fracture of the shaft. Okay. Troughing is again a problem with scarf that sometimes happens. So when you shift this bone, troughing is, if the bone is osteoporotic, it develops a trough, and then this flips, and then it can fracture, or the whole thing can collapse down and cause metatarsalgia. Avascular necrosis of the head of the metatarsal. Blood supply to the head of the metatarsal is from the plantar aspect. Now, this is not a complication that happens in most of these surgeries, but in some of the previous surgeries. Chevron, which is a very good surgery actually, chevron osteotomy, can give rise to AVN of the head. Because if your cut at the bottom goes a bit more vertical, it can take away the blood supply of the metatarsal head. then that can lead to AVN, avascular necrosis. And non-union, you can get non-union of the fracture, you can get non-union in your fusion. That is a possible complication. So what do you do to stop these things from happening? Okay, so if you're doing a scarf osteotomy, make sure you do not elevate the first metatarsal head. So when you saw the picture, so we have done a cut and we have shifted it. Okay, we've shifted the metatarsal head on the inside. Now, if your cut is going up or even neutral, there's a possibility that even if it's slightly up, then the metatarsal head which you're shifting along this plane can go up. And if it goes up, the rest of the metatarsal heads remain down, and then they get metatarsalgia. Okay, so the trick is to do when you're doing the horizontal cut in the shaft, align it slightly plantarwards. So it is going down. So when you shift a metatarsal head, you might shift it slightly down, which is fine as compared to shifting it up. So this is a very important thing. So unfortunately, I couldn't find any picture showing this, like the metatarsal head end on. Okay, the metatarsal head, if you look at it end on the medial side, has got a ridge. So whenever you do a bunionectomy, it is very sort of easy to go inside the ridge and take the whole thing off. Okay, and when you do that, that ridge is very important to stop the toe from going onto the other side. And when you do that, and that is what most people do, there is a high chance of developing hallux varus because that block is gone. So whenever you're doing the bunionectomy, make sure you go outside this medial ridge, okay? And you take whatever is outside the medial ridge off, not inside. So you have to preserve that ridge, because if you do preserve the ridge, you will very, 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 very unlikely to get hallux varus deformity. So when doing the shaft osteotomy, these blades are very fine and thin. So if you go in multiple planes, if you're going in, it makes multiple holes and it makes the whole thing very weak. And then that is what causes the fracture. So the trick is to go in completely on one side and then sort of tilt your blade in that cut and then cut the rest of it. Okay. So these are all for scarf. Aiken procedure that I showed you in that photo earlier is that osteotomy of the proximal phalanx of the big toe. It is you just make a cut on the lateral aspect and you straighten it out a little bit. It makes the toe look even better. And you can fix it with a small staple, sometimes the screw or even a K-wire. And with all of these, you have to do a soft tissue repair. So where you sort of plicate the capsule together. And the trick is you put a gauze between the toes that gives you a good idea of how much tension to give. Because again, if you don't want it too tight, it leads to, if you make it too tight, it will lead to, sometimes stiffness, sometimes it can cause hallux varus. If you leave it loose, the deformity can sort of recur as well. So you have to have the right tension, and that gauze in those big first and second toes will give you a good idea for how much tension to put. In osteoporotic bone, you have to give them a longer period of non-weight bearing, because especially if you do a scarf, they can develop that troughing in there, and that can lead to all sorts of other problems. Excuse me. If you're doing a Lapidus surgery and you're fusing the first tarsometatarsal joint, again, it is very easy to elevate the first ray while you're fusing it. So make sure that you don't do that. Some of these newer plates actually come with wedges to avoid you from doing that sometimes. So they have a sort of wedge that is on the medial side as well as on the dorsal side. So you don't elevate it too much. And when you're doing a fusion, as I said earlier, make sure you fuse in the ideal position. More dorsiflexion is better. We've had to revise one in which the dorsiflexion was too much, but it is definitely better than having it plantarwards or even neutral. So it needs to be in slight dorsiflexion to allow you to walk normally. And even if you do a fusion, people sort of can walk without any trouble. Okay. Now this is very helpful. So whenever you're doing a fusion, you need those raw surfaces. Traditionally, we used to do these flat cuts, flat cut at the base of the first on the head of the first metatarsal and on the base of the proximal phalanx. And then you sort of join it. Nowadays, you get these cup and saucer reamers that look like this. Okay, so you use this on the you use this on the proximal phalanx, and you use this on the head. Okay, and they come in differing sizes. You put a K wire in the center and you just ream around it. They really help because they will take off all the cartilage, and even after doing it, because the sort of overall shape remains, you can still alter the the angles that you have done. Once you do the flat cuts, that is your angle. And if that is not ideal, then you have to keep on cutting those flat cuts. And sometimes that used to lead to a very short first metatarsal, which again gave problems with metatarsalgia. So this particular reamers have really helped in solving that problem. And it is very easy. You just ream it, you just take the cartilage out, you prepare the joint, and you just put a plate. The plate will put it in the ideal position even after the cuts, even after the reaming have been done. So it really helps. It has made the surgery much more reliable and easy. So we are coming to the end of the talk. So the conclusions are, so avoid operating for cosmetic reasons. Okay. So this is widely done in America. Some people in India are also doing it. But as you have seen, there are multiple things that can go wrong in these procedures. So you don't want to give a patient who has a wonky but painless foot, you don't want to give them a straight and painful foot. They will never thank you for that. Okay. So make sure that you are operating for the right reason in a symptomatic patient. And if you do all the things correctly, it has a good result. However, don't wait for too long. Okay. Even if the patient is asymptomatic and I see that the second toe is starting to get affected, it will always show some signs. You will start to see those cons on the plantar aspect of the second and third toes. I would suggest operating before problems happen in the second toe, as in deformities. Okay, because once they do, you have to correct those, and the results of those are not as reliable as the first metatarsal, as in the first MTP joint. Inform the patients about all the risk factors. Okay, as I said, there is no point in hiding, because then once you do it, you will have nowhere to hide if they do get it. Okay. And post-operatively, you give a offloading shoe for about 6 weeks. They can walk on it, but in that shoe, okay, which takes all the weight on the heel. Okay, I think that's the end of my presentation. So we will see if there are any questions. Okay, Panse sir, Gosavi sir, and Chaube sir, any questions you have? Anything you want to say or talk? I think Dumre Patil sir hasn't managed to log in yet. Are there any questions from anybody else, Chaube sir?
The panelists have to ask the questions.
What are the wound complication rates? It's higher than the normal surgical.
Yes.
We do it in upper limb or above the ankle level.
Especially in diabetics. So that is why the diabetics are important, to make sure that you know that they are diabetics and you can, pay more attention. Otherwise, there is no other increased infection rate. But if your patient is diabetic, you have to be really more vigilant in these cases. And you would again protect them for longer, make sure there is no blood collection there and stuff like that. But otherwise, it's the same.
Okay, thank you.
Okay.
In a rheumatoid foot, which type of surgery will prefer?
So if a patient is rheumatoid, generally the surgery, so first of the thing, what I have found is most rheumatoid people they are not as symptomatic as you would think, even though their feet look extremely wonky, they've got a big hallux valgus, their toes are all dislocated. They're not as symptomatic as you would think they are. Okay. When you're doing a surgery for them, for the hallux valgus bit, it is always a fusion. You wouldn't do a scarf or something because there is a very high chance of recurrence in these patients. So for the first metatarsophalangeal joint, you do a fusion, and then you do like if the lesser toes are involved, then you do the typical, your rheumatoid forefoot surgery where you take off all the metatarsal heads, lesser metatarsal heads, and you fuse the lesser toes. So that is what you would do in a rheumatoid patient. So for the first method, for the hallux valgus bit, it is always a fusion.
Okay. So if a patient is having lesser toe problem, sir, when we correct the hallux valgus deformity, by their own the lesser toe problems are get solved, or you have to do something?
You have to correct them. So the picture that I showed where there was an overriding toe, you have to do fusion of that toe, and you have to release dorsally, you have to get it straight, you have to do extensor tendon lengthening, and you have to put a K-wire in it for 6 weeks.
Okay.
And that is what causes the problems later on. So even when these toes are, sometimes they are so tight, you have to do what is called Weil's osteotomy, where you cut the metatarsal and you slide it back, to shorten it a little bit. But these surgeries don't have as great results as you think. The joints in the lesser toes are very small, so sometimes they don't fuse. Sometimes they cause all sorts of problems. So I don't like operating on lesser toes. So I always try and operate before it gets to a stage where it comes to it.
Okay. Thank you, sir.
Yeah.
We have a question, sir.
Yeah.
The doctor is asking, what is your experience with triple osteotomy of the first train severe hallux valgus?
Triple osteotomy, I've never done, I must say. I've never done a triple osteotomy. I have always sort of managed to do it in a severe hallux valgus. I've always done a fusion. And again, if there was hypermobility of the first tray, then a Lapidus procedure. I've never done a triple osteotomy.
So in diabetes with hallux valgus, generally you will operate or you will conserve?
It all again down to whether it is symptomatic or not, and whether again I would treat it just like any other hallux valgus, but knowing that it is going to, I mean, you are likely to get more complications with it. But again, if it is likely to cause problems with the lesser toes, I would go towards operating. So I tend to operate on them. I've operated on quite a few diabetics without too many problems. You just need to, give them like a longer course of antibiotics to prevent any wound problems, and ask them to elevate and rest for longer than a non-diabetic patient. Or take the sutures out after 3 weeks rather than after 2 weeks.
One more question.
Yes.
I don't know I'm pronouncing it properly. It's called an effect of kinesiotape on balance in people with hallux valgus.
Yeah. So this is the newer sort of techniques that are coming in. So kinesiology tapes actually have a very good result in patients for a short term. Okay, but they will again work as long as you're using them. Long-term use, I have not seen any research or anything about long-term use of kinesiology tapes, but on a short term, they do work. Same like, these conservative measures that I said, that I showed you. The conservative measures work in the same way kinesiology tapes work also, but I don't know what are the long-term results of kinesiology tapes.
One more very different question coming up.
Yeah.
Is hallux valgus a cosmetic or a medical problem?
No, it is definitely a medical problem. In cases you will see, so that picture that I showed you with that big, under sort of overriding second toe that was going like this, you see that patient. So I've had patients begging me to cut their toes off, saying that this is causing such a big problem for them. They cannot walk. They cannot take a few steps. And in some cases, like in very old patients who are medically really poor, we have actually we've actually amputated toes that are causing overriding and pain. In which cases we could not actually do the hallux valgus correction. But in those patients very old, we decided just to take off that overriding second toe to stop the problems coming from. But that is a very drastic solution. So yes, it is a very much a surgical problem in cases, but in quite a few patients, the question properly asks, you do get cosmetic reasons to do it, and I refuse operating on such patients.
So one more question.
Wanted
to highlight your again with this question: how to recognize hallux valgus? If you have so many bullet points.
So how to recognize hallux valgus is, firstly, clinically you can see that angle. Okay, you can clearly see that the toe is going inside. You can see this bony prominence on the outside. You rule out things like gout, and you take an X-ray. And in the X-ray you can measure the angles, and that is like the most objective way of recognizing hallux valgus. But the thing to do is make sure you get a weight-bearing X-ray. So anything that is less than like 20 degrees of hallux valgus, normally you do have about 5 to 10 degrees of valgus is there in that toe normally. But anything more than that is you have to consider as hallux valgus in a mild form. So you take X-rays, and clinically you can make out, and of course rule out other conditions that present in a similar way like gout.
Dr. Panse sir was asking some question.
What is the preferred skin incision for correcting the deformity?
So it depends which surgery you're doing. For the fusion, I like to go dorsally, and also for the scarf also a little bit. The problem is that that nerve is there on the dorsomedial aspect. So some of the old time surgeons always went on the medial side completely. But I like to go more dorsally because I can see more of the joint. I can prepare it better, and you can still get a good enough sort of flap. Especially for the fusions, you go definitely dorsally. For the scarf, you can go a little bit sort of dorsomedial.
One question is coming up.
Yeah.
Treatment in helping early stages of hallux valgus.
So early stage hallux valgus, if a patient comes to me, I give them that bunion sleeve that I showed you that picture on the conservative management. It really helps. And I have seen lots of patients, it has also shown to reduce the progression of it. Okay. If they're very symptomatic, then I would sometimes ask them to use that night splint, but in most cases, just that bunion sleeve works. So early stage, not too many problems. I just ask them, you use slightly wider shoes and you use that bunion sleeve and you'll be fine. And most people are. And you get it on Amazon, which is very useful.
So any questions from panelists?
So regarding the soft tissue release associated with valgus, so how to go about that?
So you do that. Oh, that is a very good question. I was actually going to ask if Dumre Patil sir was there. So traditionally, can I share my screen again? I will just show you in that thing.
Yeah, you can go ahead, sir.
Yeah. So. Where is that slide gone? Yeah. So traditionally, what we had been taught for these, apart from, normally you're operating on this side. So you've got a very strong capsule here. So you go through that capsule and you come down. So traditionally, apart from doing these, we had been taught to make an incision in the first web space and go in and release this tendon. Okay. So one of the old-time consultants I used to work with actually used to open the joint. He didn't take this, but he used to just go from the medial side. He used to open the joint, go through the joint and release this tissue out here, okay, to help the sesamoids come back. And again, if you are removing this big pull, then there's a good chance that the thing can come back. So nowadays, so I've always done this for my scarf osteotomies, but more and more evidence nowadays is saying that this is not required. And actually, if you avoid doing it, you don't have to do another incision and stuff like that. So currently what everybody is doing is you just, that thick capsule that you have, that has connections to all of these things on the bottom, okay? So when you plicate that capsule, it automatically pulls it on the side. And as I said, that this muscle, when I do it, I take a stitch through the tendon of this muscle as well and pull it up because it has gone down. So you pull it up and you stitch it to the, plicate it along with the capsule. But generally you just do a strong capsular repair. So earlier we used to take out like a big V and then you used to join it, but nowadays we don't take that out, but you just sort of make it tight. And this lateral release is nowadays not being done. But I was going to ask Dumbre Patil sir what his experience was about doing these, because most people have stopped doing it. Okay.
Any more questions from panelists?
No.
Dr. Amrish, you want to ask some questions to panelists?
No, I think we've covered most of what can be covered in this condition. So I think we can look to end the meeting. I think we are coming up to an hour as well.
I'm just handing over to Dr. Rakesh Gosavi for vote of thanks.
Yeah.
So thank you, Bidaye sir, for a wonderful lecture. And thank you all panelists, Panse sir, technical support. Thank you, Mr. Rahul Chobe sir, and thank you OrthoTV and Dr. Ashok Sham sir, Dr. Parag Sancheti sir to giving all of us an opportunity. Thank you.
Thank you to you also, Dr. Gosavi.
Yes, sir.
Thank you all of you for spending your time and giving us support for doing this.
So I'm ending this session now.
Thank you, sir.
Okay.
Thank you.
Okay.